Some days it be like that. Okay. All right. So let's see. All right. So how many people are so ready for fall break? All right. Yeah. I mean, I feel like I could go back to sleep right now. I know. It's not just the students, it's us too. Okay. So let me move this. This is silly to have in the way. Okay. So when we get back from break, obviously no labs. Starting the kidney chapter. And if you downloaded this like early, like you've already downloaded, I updated it today to include a couple new slides. So refresh your browser for Wednesday, and then that's where we'll start. Because I'm assuming we'll finish the respiratory stuff today. Hopefully, fingers crossed. Okay. Anyone have any questions? All right. So let's get going. All right. And move this. Okay. Now this thing's always in the way. Get out of the way. Here we go. Okay, so I believe we left off. We had talked about COPD. I said this is more information on COPD, and I think emphysema and asthma, not required reading if you just want to look it over. All right. So did I get to this slide last time on emphysema? Probably not. I liked it because it gave you an image, X-ray image of what a lung looks like with emphysema. Remember, anything that causes chronic inflammation can lead to tissue breakdown. And that's exactly what happens here is the alveolar walls break down and you have these huge trapped air spaces. So you can't fill your lungs with a lot of oxygen because you can't exhale very well. All right. So that's emphysema, considered obstructive. Very, very common. These are the people who walk around, I mentioned it before, they walk around the external oxygen supply because they need more oxygen than what's in the atmospheric air. Okay. And once this has happened, it's permanent damage. There's no coming back from that. Okay. Cystic fibrosis. Anyone know anyone who had cystic fibrosis? I know one person in my life that had it. Okay. It goes to show you the power of your ion channels being messed up. We talked about sodium, we talked about calcium, we talked about potassium, we talked about chloride. This disorder is a disorder of chloride ion channels, specifically in your alveolar sacs of your lungs. So it's basically a genetic disorder. It's recessive. So you have to have a copy from mom and a copy from dad to inherit it. And what happens is chloride ion channels on the alveoli cells are messed up. So you know that thin water layer that I was talking about that's supposed to help gas exchange? It's supposed to be fairly liquid, not viscous, just thin water layer. With the chloride ion channels messed up, instead of a thin water layer, it becomes like a thick, sticky mucus, and that becomes a problem. All right, so they basically are living with chronic mucus buildup in their lungs. So imagine, because flu season is here and cold season, and when you have that inflammation fluid in your lungs, the mucus, and you're trying to cough it, you know, when you cough that deep chest cough where it almost hurts, that mucus you're trying to bring up, they're living with this. This is their condition. All right, so the mucus dilutes the surfactant. So now their alveolar sacs want to collapse. So they've got that problem, non-obstructive atelectasis. There's less size to the alveolar sacs, so they can't fill it as much of the air because the mucus is taking up some of that real estate in the alveoli. And the big thing is they're not doing gas exchange very well. They're not able to respire very well. And with that mucus living there in their lungs, it's a good breeding ground for bacteria to set the stage for a secondary bacterial infection. All right. So, well, anyway, so anyone who knows anyone who's had a kid with cystic fibrosis, what she's doing, she's not doing the CPR. You know, this kid's wide awake and everything like that. What they're doing is they're massaging the chest, and they're also hitting the back a little bit to break up the mucus so the kid can expectorate it out and get it out of the respiratory system. You know that Mucinex that they sell at the store for when you have that mucus? And yeah, so they have stuff like this for these people who have this condition. It can significantly reduce life expectancy, unfortunately.
Is it like is there like levels to it where some worse than others?
Yes.
I think honestly that's just.
There's so many respiratory things. You'd have to go to the doctor and get on a spirometer, which we're going to talk about, how you diagnose respiratory disorders. Image x-rays, imaging, CT scans, spirometry, doing good bacterial cultures, things like that. So yeah, it's very possible. And then of course, genetic testing. If you do genetic testing on someone who you suspect has this, they would come up homozygous recessive for this disorder. All right, so that's one way to do it that's not invasive. But yeah, I knew one person, and he didn't live a long, full life with this. But that was back then. They probably have better treatments now. Okay, so how do you diagnose people with respiratory disorders? Now, we had a really cool spirometry lab. I'm just not comfortable yet with COVID and the flu and all this stuff to start doing this lab again, but it was really awesome. You breathe into this device just like this. We have just like this, except we have a cardboard mouthpiece that's disposable. And this right here is a bacteriological filter. It's not a viral filter because viruses are too small. And that's why I kind of have held back on doing the lab. I just don't want a bunch of you breathing into a spirometer and then contracting viruses from each other. But this is something that can be done. Nurses can do this stuff. It doesn't take special techniques or training or anything like that. But you can measure lung volumes, how deeply you breathe in, how deeply you breathe out, what your inspiratory reserve, how deeply can you breathe in, how deeply can you breathe out, and all these other things. And then there's of course normal ranges for men and women. And so you probably learn more about this in nursing school. But this is one way to do it, is how are they moving air? Okay. Since we can't do the lab, I'm just going to say spirometry is you breathe into a device like the sensors that we have, like the dynamometer. It's just you breathe into it and it records it on a computer. Really easy. All right. The other thing, other than maybe genetic testing, if you think it's genetic disorder, is X-ray. Okay. And then there are X-ray technicians, people who specialize in reading X-rays and CT scans. All right. That could diagnose from that. Okay. Like I said, it takes some training. You could show me a bunch of X-rays back to back to back that were respiratory disorders. And unless I saw a big mass, they would all look the same to me. All right. So it takes some training. Okay. So we covered a lot. Talked about lung cancer, chronic bronchitis, asthma, emphysema, pneumonia, cystic fibrosis, and that stupid thing is blocking what this is. It's probably the flu and stuff like that here. Influenza. Okay. We're missing some students today. And I know some people took an early fall break. I know I'm not stupid, but there are some people that are really sick, like really sick. This flu, like when I get out today, I'm going out to CVS and getting my flu shot. All right. That's how bad it is. This person emailed me and they're so sick. They've been to the emergency care. That's how bad it was. All right. So don't forget about the flu. And of course we could add COVID and all COPD and all these things. All right. So we've covered a lot of stuff. Here's some vocabulary, very simple vocabulary that I think you should know about breathing. So the first one, apnea, pnea, pneumo, all right, pneumothorax, all that stuff means basically your lungs or air, all right? The A in front of pnea means absence of breathing. That's always bad, all right? That's when you CPR trained individuals start your CPR and respirations and things like that. You code a person, right? Dyspnea, we've talked about, was it the taste lab? Dysgeusia? Yeah, it was distorted taste. Remember that dys in front of something means distortion or difficulty. So this is labored or difficult breathing, which someone who has a respiratory disorder might have. Eupnea, that's how it's pronounced, is normal breathing, no problems. Okay, now hyperventilation, hyper means excess and ventilation is breathing. So they're breathing rapidly, all right? That will mess with your blood pH, and I'll explain in a second. Then hypoventilation is low ventilation. So you can either be holding your breath or think of someone with cystic fibrosis, think of someone with emphysema, think of someone with any kind of asthma, okay? They might not be respiring enough because of that disorder that they have. That's going to mess with your blood pH. I'm going to explain it a little bit later, but let me simplify it for you. If you're holding your breath or you're not ventilating enough, all right, you're basically starved for oxygen. And what's happening is you're not getting rid of that CO2 waste in your lungs as you should be. So some CO2 is remaining in your bloodstream. CO2 is acidic.
And so when you're hypoventilating, it doesn't take long. I mean, we're talking 40 seconds to a minute and your blood pH is already shifted. So if you're retaining CO2 because you're not getting rid of it and you're not ventilating, your blood pH drops. We know that as acidosis. If the acidosis is a result of what the lungs are doing, it's called respiratory. See? We're all suffering. Okay. It's called respiratory acidosis and it's bad. All right. That's bad. If someone is hyperventilating, which certainly could happen, they're breathing, right? That's bad too. You're actually losing too much acid out of your body. And so your blood pH rises, and that's alkalosis, going all the way back to chapter 1. But if it's because of what the lungs are doing or not doing, it's respiratory alkalosis, and it's equally bad as acidosis. Okay, and I think we talked enough about pneumothorax. So just vocabulary, I think you should definitely know. And I'll talk about this in a little bit because it's a small pathway. It's a negative feedback mechanism. Okay. Since it's not on the slide and I can just talk to you, which sometimes I like to do because then you're listening and then it's going in your brain, hopefully. If your blood pH drops, you have chemoreceptors because pH is chemistry. All right. You have chemoreceptors located in the same place where you have baroreceptors for blood pressure. And where would those baroreceptors be located? Aortic arch, carotid artery. You have chemoreceptors there too that are testing blood pH. And guess what? If your blood pH drifts outside of normal range, those chemoreceptors signal well, what would the baroreceptors signal as the integrating center? The medulla, the same place for blood pH. The chemoreceptors signal the medulla, and the medulla we know has a cardiac center, a vasomotor center. It also has a respiratory center. And so the medulla will change your respiratory rates by stimulating your muscles. So if your blood pH is too low because you're not ventilating enough, the medulla is going to stimulate increased respiratory rate. So you breathe more deeply and rapidly and hopefully blow off all that CO2 to bring your blood pH up. If your blood pH is too high, the medulla is going to stimulate a decreased respiratory rate and depth. So you retain a little CO2 and your blood pH comes back down to normal. So it's a similar pathway, see, respiratory, that you've already learned. Bless you. Need tissues? Tissues? There's no shame in it. Yeah. Thank you. Hopefully with this fall break, treat yourself nicely, rest up, because it's only going to get worse from here. So a system you already know, negative feedback system you already know, tweaking it, chemoreceptors, and what your lungs are doing. So when we get to that section, I'll be able to go over it fast. Okay, so here's how gas exchange happens. Real simple. It's passive, mostly passive. All right. We know from cell transport that particles move across the membrane from high to low. It doesn't take energy. That's the preferred method. And so it's passive. Your gas exchange happens the same way. So if we're talking about gas exchange across your alveolar cell walls, oxygen will always go from high to low. CO2 will always go from high to low, passively, all right, by diffusion, but it's gases. Okay. So here's what's happening with gas exchange in your lungs. And it'd be very similar with gas exchange between your arteries and your tissues. So in your alveolar sacs, oxygen is 105. Don't memorize these numbers, it doesn't matter. Where is oxygen higher? Where is it lower? In the alveolar sac, it's high. Okay, so here we have pulmonary arteries coming down to small little capillaries that are wrapped around the alveolar sacs. The oxygen in the pulmonary arteries is lower than what's in the sac. So where does oxygen go? It leaves the sac, goes into the vessel, and then it becomes a pulmonary vein going back to the heart with oxygen. Where is it high? Where is it low? That's where it's going. Now, CO2 in the pulmonary artery is 46. In the sac, it's 40. So it's higher in the vessel than in the sac. So it goes from the vessel into the sac. And then when you exhale, by CO2, that's it. That's what happens. Okay. Okay. So I'm not going to make it any more complicated than that. If I have a future test, and this would be in a final, I would ask you, where is oxygen going? And I'll give you oxygen partial pressures in a blood vessel versus a tissue or an alveolar sac. And all you have to remember is, where is the number higher? Where is it lower? It's going to go from high to low. That's it. Simple as that. All right. Okay, in your tissues, same concept, high to low. So here we have an artery, systemic artery going to a systemic arterial capillary. And the big arrows mean that's a higher pressure of that gas. In the artery, oxygen is something around 100. In the tissue, this case muscle tissue, it is something smaller than 100. So oxygen goes from the blood vessel into the tissue because it's going from high to low. In the tissue, because it metabolizes, it goes through aerobic respiration, it produces CO2 waves. CO2 is something higher than 40, and in the vessel, it's 40. All right, so here it's higher in the tissue, CO2, lower in the blood vessel, so CO2 leaves the tissue, enters the vessel, and now it's going to go through veins back to your heart, carrying that oxygen away. High to low, that's it. I need to explain it any more in depth than that? Is that pretty straightforward? Okay, because textbooks make it really complicated, but it really isn't. Okay, the chemoreceptors. There's actually two. There are chemoreceptors in your aortic arch, carotid artery. We know baroreceptors there, so it's not that much new information to learn, but that's testing blood oxygen and CO2 levels. And of the two gases, these chemoreceptors are more in tune to CO2, right? Just kind of the way it is. Your medulla itself has chemoreceptors. They're called central chemoreceptors. It's testing cerebral spinal fluid, oxygen, and CO2. Because back in the central nervous system, I said the brain tissue itself, especially the brainstem, is not exposed directly to blood because it's too important. That blood could have pathogens or toxins or who knows what. So the only thing bathing those tissues is cerebral spinal fluid. So you have to have chemoreceptors there to detect the change in blood pH. So the integrating center itself can detect a shift in pH, basically. All right, so here is the control of breathing. So back to central nervous system, when I talked about the frontal lobe and the motor cortex that controls all voluntary movement, you can make yourself breathe in deep, breathe out deep. You can make yourself breathe rapidly. You can hold your breath to some extent, all right? That voluntary breathing is the motor cortex in the frontal lobe that controls anything voluntary. But the involuntary stuff, so when you're not thinking about it, when you're asleep or otherwise unconscious, that is controlling your respiratory rate and depth. And the medulla, I'm going to circle it. All right. So let's flip this around here. And let's move this out of the way. Maybe up here. The medulla is the most important one. Okay. Let's change the pen. The medulla tells the pons what to do. Yeah, the pons has the apneustic and pneumotaxic centers, but the medulla is telling the pons what to do. So the medulla is running the show. So I really just talk about the medulla just to simplify it, okay? It's regulating your respiratory rate. And it does it based on what's going on with your blood pH, okay? So don't memorize. I don't think I'm going to ask normal ranges of blood pH. You'll learn all that good stuff when you go to nursing school. But it's within a very narrow range, okay? Outside this range is death for, if it stays there for a long time. And so blood pH is maintained by buffering the CO2 with bicarbonate ions. This is inorganic chemistry, right? So when we get to the kidney system, I'll talk about how our kidneys retain bicarbonate ion and put it back into the bloodstream because it's buffering our blood. Blood that has a lot of CO2 or hydrogen ions is acidic. And if it has low CO2 or high bicarbonate, it's leaning towards alkalosis, all right? So blood pH is really based on blood CO2 because that's the acidic molecule, all right? And of course, what you're metabolizing. If you're metabolizing lactic acid, fatty acids, all those acids, that can change your blood pH, but I'm not going to go back over that stuff. Okay, so vocabulary, minute ventilation. That is the depth and rate of your breathing. How deeply are you breathing in and out and how rapidly per minute, okay? So that term I'm going to use in the pathway, which is this, okay? So if you hold your breath or holding breath, oops, where's my pen? Or hypoventilation. Someone's not respiring as well as they should be. Maybe they've got a respiratory disorder or cold or flu. you're not getting rid of enough CO2. CO2 is building up, okay? That is sensed by your chemoreceptors in the aortic arch, carotid arteries. It will send a signal to the medulla's respiratory center, and it will change minute ventilation. So in this case, you've got to get rid of CO2. So it's going to increase minute ventilation. The effect is you lose the excess CO2. You're losing the acid. And so by losing the acid, it increases blood pH back to normal. And it fixes it like when we did the lab, after holding your breath for 40 seconds, people are like, oh, 40 seconds is such a long time to hold your breath. It kind of is. But after maybe 10 seconds of breathing, after that challenge of rapid breathing to get rid of that CO2, everyone's breathing came back to normal real fast, real quick fix. All right. Again, the medulla is always a quick fix. All right. Now, the effectors are your respiratory muscles. Think of your diaphragm, all the other respiratory muscles. That's what's happening. Okay, so the opposite, I don't know why this is going backwards. All right. Now, if you're hyperventilating, let someone say they're panicked, anxiety, panic attack, right? Heart rate goes up, respirations go up, their blood pH is going to change. So now you're breathing excessively. Now you have the opposite problem. All right. You're losing too much CO2. Your blood pH is going to rise because you're losing too much acid from your respiratory system, respiratory alkalosis. So the stimulus of the low blood CO2 sensed by the chemoreceptors signal the medulla. And now the medulla is going to tell your respiratory muscles to slow your respiratory rate down, decrease minute ventilation. All right. I'll underline it. Decrease minute ventilation. So what happens is you are retaining less CO2 is being lost in the environment. By retaining that CO2, brings your blood pH back down to what it should be. So that's not a bad pathway, right? Because you already know about the blood pressure receptors and what the medulla does. Now we're just changing it to chemoreceptors, the medulla, and now minute ventilation. All right. So I think that is the only pathway in this chapter. Yes, it is. Okay. So now I think what comes next is hemoglobin disorders, a few of them. All right, so we're definitely going to finish this. Do not memorize all this stuff, okay? Don't memorize all this stuff. But I do want you to know the vocabulary words, what I'll get to. But hemoglobin is your respiratory pigment. That binds to oxygen and releases oxygen at your tissues. It is the waiter that brings all your tissues the oxygen their tissues need for aerobic respiration. So, and that's what it looks like, okay? And it's got different subunits of the hemoglobin molecule. It has heme groups here. That's why it's called hemoglobin. It binds each heme group. Okay, heme binds with one oxygen molecule. Okay, every red blood cell has millions of hemoglobin molecules, so that's a lot associated with it. All right, now here, when hemoglobin is maximally bound to oxygen, it's called oxyhemoglobin. Now, how do you know if someone's red blood cells are maximally bound, the hemoglobin on their red blood cells are maximally bound with oxygen? This pulse oximeter, which you will be very familiar with in a hospital setting, because you want to know this COVID patient, this COPD patient, this, emphysema patient, how good is their oxygen supply? When do you need to intubate them because they're not respiring enough? Hook them up to a pulse oximeter, and it's going to measure oxygen saturation, and it says 97%, and 97% is what it should be. If it's dipping below that, and I don't know the break-off point where they say, okay, this person has to be intubated, but you'll find out in nursing. All right. Hemoglobin that is lacking oxygen is deoxy, so less oxygen on it. And I color-coded it. Arterial blood, that's very bright red. It's bright red because of all the oxygen on the hemoglobin. And venous blood, I think you probably noticed this before, is more of a dull red or a maroon color, because it's got less oxygen on its hemoglobin. So this could be happening in someone who's not ventilating enough, or you simply could be looking, that's the person's venous bloodstream and it's carrying deoxyhemoglobin. All right, but this right here, you'll see that, you'll have it on patients where you're concerned about the respirations. How many people have had one on them in a hospital? I had when I went through surgery. They're monitoring that during surgery, okay? Okay, so hemoglobin disorders, I'm just going through the main ones. There's lots of them, but okay, we're getting into the cold, not cold flu, but yes, that, but temperatures are going to start to drop sometime around December, get really cold. And we live in an area where there's a lot of rural communities. A lot of people are economically depressed and they might not even have a heat pump that can heat their houses. And so what they do, I mean, you have to, is other than piling a bunch of blankets on, is sometimes people use a kerosene heater inside their house. Some people, I have a wood stove, you know, like a fireplace that burns wood, not propane. I have a carbon monoxide detector in my house because if you're burning fossil fuels or things like kerosene, it can release carbon monoxide gas when you burn wood. All right, it can release carbon monoxide gas. If you're in an enclosed space like a house and the windows are all shut up and everything like that, that carbon monoxide gas is odorless, tasteless, you can't see it. So how do you know it's in the air? And here's the problem. Carbon monoxide preferentially binds with your hemoglobin. It will knock oxygen off your hemoglobin, and it has a higher affinity for that hemoglobin. So carbon monoxide gas is going to bind to your hemoglobin, not oxygen. And when that carbon monoxide gas on the hemoglobin is called carboxyhemoglobin, when that gets to your tissues, it ain't got any oxygen. So you're going to go hypoxic. You're going to turn blue. And really what will happen if it's in your house and it's building up, okay, you're going to fall asleep because your brain's getting less oxygen. And if someone doesn't come to save you, you're going to die. All right. It's the same thing that happens when people are in a car. Unfortunately, sometimes people use that as a way to kill themselves by basically taking a hose to their exhaust pipe, putting it into the car, rolling up the windows. It'll work. It's going to be carbon monoxide gas. And in that tiny enclosed space, you're going to fall asleep. You're going to die. All right. Your brain's going to go without oxygen and it's going to shut down.
Unfortunately, I saw this lady, her and her son was sitting in her car in the yard. She had a car running and they both died.
The garage is an enclosed space. And, you know, and you do have places that air can get into your car. That's why we have air filters, right? So if it builds up enough, that can, even if they don't have their windows open, it can still make its way into the car. That's sad. So, you know, people should have carbon monoxide detectors in their house, definitely. And you're going to see cases like that, or someone using a kerosene heater in their house. All right. So yeah. All right. It's the only way we'd know what's building up. If you don't have if you're not using a propane heater or anything else like that, or burning wood in your house, is there a chance that carbon monoxide can build up? Less so, not so much. But those are the main risk factors that you're going to see. And I think there's cases every single year from people using kerosene heaters in their house. I know I did one time. We did. Because it was a hurricane. We got our power knocked out for 5 days, and we didn't have a generator that was strong enough to run our heat pump. And so it was very cold. And so we were burning wood in the fireplace and just kind of living out in the living room. And that's we made sure to put the carbon monoxide detector like right there, because, you know, we're setting ourselves up. So carboxyhemoglobin is basically the hemoglobin is bound to carbon monoxide. That's what makes carboxyhemoglobin, and it will displace oxygen. And as it gets down to the tissues, they're not getting any oxygen. Where our cells can't use carbon monoxide for anything. All right. So your brain will go quiet first because it's got the highest metabolic need. So yeah. All right. Okay. Here's another thing that I think that you might see because we live in an agricultural community. So methemoglobin. All right. So just met and then hemoglobin. And anemia means you've got this type of hemoglobin in your blood. It's a disorder where the hemoglobin's iron is ferric rather than ferrous. So the importance of chemistry in our body, right? That one little change makes the hemoglobin methemoglobin. Methemoglobin doesn't want to release oxygen. It's changed it chemically. So when it gets to the tissues, the hemoglobin, instead of letting the oxygen go, holds on to it. Same problem as carboxyhemoglobin. Your tissues are now not getting oxygen. It's there, but it's not being released. Okay. So you're oxygen starved and the patient's turn blue. That's a sign of hypoxia. All right. The bless you, the sim models they have in the nursing department. He's called Mr. Manuel. He can actually turn blue. He can. And so when you start working with that simulated model, it can actually turn blue on you. Now, blue baby syndrome, did anyone learn about it in microbiology? Because I think Dr. Pryor covers it. Maybe not. Okay. Babies turn blue from drinking milk formula, not breast milk. All right. Formula that is mixed in with water that contains nitrate. Where does nitrate come from? Nitrate is applied to agricultural fields for plants because nitrate helps plants grow. What nitrate the plants don't absorb and use runs off with rainwater, leaches down into the ground, into the aquifer. So if you have people who live out in the country, I live out in the country, all right, we had to get a well dug. We made sure and had that sucker dug real deep, all right, like 300 feet, because around 100 feet, that's where a lot of, we live next to a sod farm. So they applied nitrate to make the grass grow so they could harvest the sod to send it off to people to sod their lawns, right? I thought, oh boy, there's going to be some nitrate here, all right? So we dug the well really deep, and the first thing we did is we got the water and we sent it to Clemson Extension and tested it for nitrate. And fortunately, it was clear because the well was really deep. But some people are going to live out in the country, get their wells dug, and they might have, if they live next to a lot of us who live out in the country live next to agricultural fields. That well water could be contaminated with nitrate. And if you have a young baby and you're making up formula with that water, this is how they can get this blue baby syndrome. All right. So someone comes in and their baby's blue, and you run through the battery of all these tests. And in this extensive patient history that you will be taking, you find out they live out in the country. They just moved out there about a year ago, had the house built, well dug, everything. And then they had a baby. And for whatever reason, the baby's on formula instead of breast milk, and this baby comes in blue. That actual patient history might really be important. So they test their water, they find out they have nitrate, all right. So either they make the formula with bottled water, which I'm not even convinced is safe because of plastics and everything. Does anyone know how you fix nitrate in your water, coming through your water? Filtration system, right? A reverse osmosis filtration system that you can hook under the sink is going to take out that nitrate, among other things. All right. So there is a fix for it. But yeah, will you see it? Possibly. Yes, absolutely. First of all, they stop getting that source of water into their body. And hopefully, and the baby might need a little mask work and everything like that. But yeah, they will recover from that. All right. But you got to know where the source of the problem is. Okay. Neonatal jaundice. How many people have heard of someone who's had a baby that had jaundice? It's very, very common. Babies come out, they're not fully cooked. All right. Even a baby that's gone through the full pregnancy, they weren't born early. Okay. They just were born on a normal schedule, but maybe their lungs still aren't quite up to snuff. And their liver, more importantly, is not up to snuff. So what happens back when I talked about red blood cells, right? And I said, our red blood cells, we produce millions of them every day because the red blood cells live for 120 days and then the body breaks them down because they're old, okay? And when you break down the red blood cells and the body's recycling everything, you release a yellow pigment called bilirubin into the bloodstream. And if your liver is functional, it will remove that bilirubin from your bloodstream. So your liver is a filtering organ, okay? Babies born whose liver is not quite up to the task, here's what happens. When the baby's in the womb, its mom's body is providing all the oxygen and getting rid of CO2 through the placenta. And so the baby's liver, it doesn't have to do a lot of work because mom's body doing the filtering for it. The baby has fetal hemoglobin, and it functions differently than adult hemoglobin because mom's body is taking care of all the baby's need. When the baby is born, it's now autonomous. Its own circulatory system and lungs and liver have to handle all the work itself. All right. Mom's not there anymore. We're separated. So the switch from fetal hemoglobin to adult hemoglobin happens real quick for a fetus. As soon as it's born and is exposed to atmospheric air, adult hemoglobin is being produced by their bone marrow. And now the fetal hemoglobin is being broken down because it's not going to be useful anymore. And all this bilirubin is being spilled into the baby's bloodstream. If its liver is not mature enough yet to filter out the bilirubin builds up. And then the baby turns yellow. The whites of its eyes are yellow. The gums are yellow. All right. Because the liver's not mature enough yet. What's nice is you can expose the baby to blue lights and it will change that bilirubin down to something water soluble that the kidneys, if they're functioning, can get rid of. All right. So if it's really bad, the baby stays in a NIC unit, all right, neonatal intensive care unit, and they apply the blue lights and they monitor it very carefully. If it's just a modest case of neonatal jaundice, not that bad, you can actually have a small portable blue light and the parents can take it home and do the blue light treatment at home. All right. Has anyone ever heard of this or know someone? Yeah. All right. How long, do you know how long they had to do it?
Yeah, my sister was born at 6 months. My mom got her at 6 months pregnant.
So that was early.
She was like a pound.
Wow.
No, I didn't have fingernails or anything. She was in the NICU for like 3 months.
Okay.
And they sent her home.
With the blue light. Okay. And do you know how long it took? I mean,
No, I
maybe
was- I
you were
was
young.
3.
Yeah. You don't remember that. Yeah.
She's 16 now.
Yeah. Well, see, it's very treatable. All right. This is not something that babies usually die of because it's so common. You're expecting it as the nurse who's attending there and you're ready to, help along with that. Okay. So here I'll let you read it on your own, but it's basically talking about the switch from hemoglobin F to hemoglobin A. All that hemoglobin F has to be broken down, those red blood cells, and that causes the problem if the liver's not functional. And then the last thing is sickle cell anemia. Again, very common. What it is, it's classified as a hemoglobin disorder because you produce hemoglobin S, the S for sickle cell, rather than hemoglobin A. All right. So homozygous recessive condition, the people who inherited a copy from mom and from dad are going to show the symptoms. We've now found out, because we're always finding out new things in medicine, that even just being heterozygous, you inherit just one copy, you can display some of the symptoms of sickle cell. And sickle cell is a sliding scale. Some people have it really bad, some people not so bad at all. It's just variation. But because of that hemoglobin S, that is what makes the red blood cells take on the sickle shape, right? And because of that shape, they don't carry as much oxygen as they should. So we have the reduced oxygen. Because of that shape, the red blood cells want to stick to each other and form a thrombus. And if you can form a thrombus, that thrombus could go floating around in the bloodstream and it could get lodged in a small artery and block blood flow. And then you have an ischemic event, which is a loss of blood supply to some tissue in the body. All right. And many other things other than this. But yeah, that I think ends respiratory system. So guys, go forth. Have a good fall break. Be safe out there. All right. Flu cold is out there, so wash your hands a lot. All right. And I'll see you on Wednesday. Have a great break.
Thank you.